soft tissue response. And in this case, we are not following the soft tissue, but it's the soft tissue that follows us. That's a great deal, I think. Much, much easier. And of course, should we know that the prosthetic margin are located nearby the cementum and junction? We don't need that anymore. So this is ideal for compromised cases where we really have to decide what to do. Which are the advantages? I'm going to show you now a clinical case in order to understand the process, the protocol of the BOPT. Well, the advantages are many. First of all, in a case like this, I have recession. Probably is a passive extrusion of the tooth, and I have exposure of the root. And also, if you look carefully, we have a gingival color changes, right? So I'm thinking, yes, I can still do a chamfer because I can be minimally invasive, I can be nearby the gingiva, the anatomical and clinical crown still coincide, yes. But the soft tissue is not thick enough. And again, how can I be predictable and in order to decide which kind of soft tissue I'm dealing with? Is a thin soft tissue? Is a thick soft tissue? Do you know? I don't. Actually, I don't. I will show you. We don't have time, but I can show you an article that they demonstrate that in the 25% of the cases, we don't know exactly which kind of biotype we are dealing with. So, in a case like this, even if I can still go through the chamfer, I prefer to go through the vertical preparation. Because through the vertical preparation, I can also have a beautiful response from the soft tissue, and I can demand my soft tissue to get thicker and thicker. And when I got thick tissue, well, I won't have any more color changes of the gingiva. And the first question, anytime we do go through the BOPT, is how deep is the bone below gingiva? So in the protocol, anytime we have to touch the teeth, we should go through the probing, understand where is the bone, try to understand, but I don't know if it's easy to do it when we're dealing with a thin or thick biotype. But it doesn't really matter with the BOPT, because with the BOPT, we can achieve a biotype conversion. I mean, we can expect the soft tissue to get thicker, which is amazing. Because anytime I got a thick tissue around my tooth, my veneer or crown, or around my implant, I've got the natural barrier that protects my tooth and my implant from the external world. So for me, manage and manipulate the soft tissue in an easy way is fundamental, is mandatory. How deep is the bone below gingiva again? And when we remove the crown, you can see, is the soft tissue here thin or thick? What do you think? Is the thin tissue? How many of you think is a thin tissue? Yeah, I think so. I think so. Then I will show you that it can be thick later on, without any surgery. So, which biotype? Thin, normal, thick? Well, yes, probably thin, but I don't care anymore because I know I can have a biotype conversion. And let's go through this. I try to measure it, and when I go with my bore into the sulcus, what I do is to remove the remain of the chamfer. I just want to have a vertical wall where I can still think which is the final positioning of my crown margin. It's very easy. So we get into the sulcus with the bore. We do have a gingitage as well because we touch in the gingiva. We have blood as well, but patient, believe me, don't go to hospital. They don't die. They're safe. And they don't even realize that we are touching the gingiva, okay? So for some periodontists, it could be like, what you talking about? Sto ti děleješ? Nothing. The alternative was a connective tissue graft. What do you think? Is more aggressive a connective tissue graft or getting with the burr gently into the sulcus and maybe induce a little bit of blood? Like Mario before showed you a beautiful case on the palatal side when he got deep inside and he was bleeding. But after a while, the gingiva was perfect. So you can invade with your burr the sulcus. Nothing's going to happen. So we go through, see, we go through the process, removing all the chamfer. We can touch the gingiva. That's why I don't like the burr with the polished tip. It doesn't make sense to me because I really want to touch the gingiva. And when I do this, I can polish them, and after that, we have, of course, a kit of burrs if you're interested, but you can get the code and buy it one by one and make your own kit. It's very easy. At the very end, we need 3, 4 burrs to do that. It's not important. The BPT is not about the vertical preparation. You need the vertical preparation in order to achieve the final results with BPT. But it's not about vertical preparation. So the key to understand the BPT starts from the provisional. After the preparation, after we've been invading the sulcus and we removed all the horizontal components, then we have a straight wall, vertical, 3/6 degree. And what we can do, we get the provisional and we go through the relining of the provisional, like we do with the chamfer, but without the limitation of a finishing line. We go relining our provisional, and with the resin, acrylic resin, okay, not bisacryl or other stuff, acrylic resin, we get into the sulcus. So we want to read apical into the sulcus, no problem. We do this, and then we have the provisional. And as you can see, we have the apical part of our preparation here. This is the apical part. It's not a finishing line, it's a finishing area. Okay? With the chamfer, we have a finishing line where we think we're giving to the technician the information to start with the crown. In this case, we just have a finishing area. And we want to create a thick margin because the margin of the crown is the landing area for the soft tissue to adapt on. So this is key to understand the BOPT. So I mark my apical part, then I go through the laboratory process. I want to fill the apical part with resin, and then I create a thick margin of my crown. See, here. I fill it up with flowable resin, or it can be flowable composite. So I create a thick margin, but of course this margin is too apical. So I want to also to shorten my provisional. And then after that, I remove the X-axis, I shorten my provisional, but I still don't have the information. Where is the gingiva? How deep I've got into the sulcus with my margin? But I go back to the patient at the church side and I place the provisional intraorally. And in this case, see, I've reduced the length of my provisional in order not to be aggressive, not to push too much the gingiva. But I still don't have this information. So I just need to do that and then go intraorally. And intraorally, I have a surprise. If I'm a little bit skilled because I know what to do, I can get very close to the final crown margin. If not, doesn't matter, because I can still make a double check and make sure that the margin will be where I want the margin to be. So we have 2 lines here. One is outside. I draw the line just to show that I want the gingiva to be there and symmetrical to the other incisor, central incisor. There is another line you can't see because we have the blood. But there is another line, juxta. When I remove the provisional, as you can see, we have the juxta line, kind of, and the other line, which is the line where I want the soft tissue to be. So in the first place, when I do my preparation, I'm not expecting the gingiva to get coronal because it's too thin. You told me before, when I asked you, what do you think is this gingiva, thin or thick? And somebody told me, yes, it's thin. It's very thin gingiva. So how can I expect the thin gingiva to get coronal? So the first thing I want to do with my gingiva is to create a thicker tissue. This is what I do. So I can remove this part, apical, and be juxta. I can be at the gingival level with my provision. I never, never, ever invade the sulcus. If the gingiva is apical, I just get apical with my provisional at the gingival level, no more than that. Then, of course, my goal is to get coronal to the second line. How can I do that? Well, I just have to be patient. So I just finish my provisional. As you can see, the provisional has got a thick margin because the margin is the landing area for the soft tissue to adapt on, okay? Like we saw before with the overcontour on natural teeth. We have a cementum enamel junction and then the overcontour. And the gingiva probably respond to this anatomical situation in a specific way. So we get this landing area, and then we just have to wait. We wait, like as a protocol, 20 days. And in the 20 days, the soft tissue will get thicker. Not coronal, just thicker. When I got thicker tissue, I will show you, I can, after 20 days, shorten my provisional and recreate a symmetrical line according to the other central incisor. But I have to wait at least 20 days. It's a biological time. Shortest time, but enough to expect the soft tissue to get thicker. After that, I shorten my provisional. And what happens? The soft tissue will follow me. So for the first time, I don't have to follow the finishing line. I don't have to follow the soft tissue, but I'm expecting the soft tissue to follow me. And then, day by day, as you can see, the soft tissue gets closer to my new margin of the crown, which is to me the new prosthetic cementum enamel junction. No more than that. So this is key to understand the process. And day by day, the soft tissue will adapt on it, will settle on it, will be perfect. The more I wait, the better it is. After more 20 days, I want to get my soft tissue more coronal. Okay, I can shorten again my provisional. And after 10 days, 2 weeks, depends on the patient, depends on the biotype, it depends on the quality of the soft tissue, the quality of the hygiene. There are many, many different situations. But for sure, if I'm patient, day by day, the gingiva will adapt to the new shape I'm giving to the crown margin, to the new prosthetic cementum enamel junction. And before the final impression, I'm asking you again, is the soft tissue thin or thick? Thick? Yes, I think so. Now I have a thick tissue. Before, nie znаю. Może być thin. Now, nie znаю. Thick. So I have kind of, I don't know if I'm allowed to say it, a kind of biotype conversion. So I have gingival thickness, and when I have thickness of the gingiva, I'm pretty sure, I'm comfortable, because I know that the thick tissue is going to be stable in time. So these are the biological advantages. So from here, if you remember, we get here. It's a complete different situation. Now I'm comfortable. The chamfer there, now I don't have the chamfer anymore, but the chamfer is in the crown itself, in the margin of my crown. So I go through the simplified adhesive cementation, and well, Mario, Davide Cortellini, Angelo Canale are friends, and I've been following the protocol from the article, Simplified Adhesive Cementation. So how can I do this? I can't place the clamp, I can't do traditional adhesion, but I can do my best in order to isolate the field with a rubber dam, kind of Brazilian style or whatever, Turkish style, but it works. You can work with cords, cottons, try your best to make the isolation, and then go through the cementation. And of course, when you do that, it's kind of predictable. You can use different kind of cement, self-adhesive cements. Very, very easy. And the funniest thing is that, so for some people, they might ask me, but if you do this, then if you have a silicate, for example, you might break the margin of the silicate. No, not at all, because it's a monolithic crown. I want to have a thick margin because I'm removing the chamfer, and the chamfer is in the crown margin itself. So I'm working with a thick margin, and the thick margin won't break. I'm safe. So monolithic lithium disilicate, simplified adhesive cementation. I do light cure for a few seconds. I remove the sacs, air block, and I'm done. I will show you then, in other cases, if you blow the air, the gingiva will rise, and you can see 360 degree that your margin is juxtagingival, and you can check if you have cement. So it's very predictable also, the cementation. We go through the air block, wait. This is day 0, I don't like it. And of course you can make mistakes sometimes, but it's kind of nice mistakes. After a few days, after a few months, the gingiva will adapt on new shape and will settle on the new Burgess profile of the crown. Okay? So this is what happens. And believe me, if you're gonna try not on a central incisor, but if you're gonna try on Monday morning on a premolar of your papa, of your babushka, you can be very minimally invasive, and for sure you're gonna see beautiful soft tissue. And your babushka will be so happy, because the alternative was a connective tissue graft. So you decide what to do, right? 6 months later. And which is the real power of BOPT? For dramatic cases like this, for example, what can I do in a case like this? Yeah, you might think Yakultoi, I can do crown lengthening, I can do whatever I want. But at the end of the day, all the other protocols are difficult. So should I prepare for a yeah, look at the route. Well, the alternative, yes, we have an alternative. Extraction, implant, fast, and money. Why not? You can decide, but I'm still from the patient side. I have an ethics, and I think like my patient is my babushka. So I don't like this kind of approach. I don't want to be aggressive. And if you can see, I can do my build up, I can do my vertical preparation, and in a case like this, I got close to the bone, and nothing happens. The bone is still there. I don't have recession. I don't have all the, devil stuff that happens around the tooth when you touch the tooth in such an aggressive way. Not at all. So we've been learning for books many, many things, but today I think we should also change our point of view, our vantage point, and look at the books from a different point of view and think on our own. So anytime I do this, look at the cord. Do you think that the cord is going to be aggressive and responsible for the recession? Do you think that? Of course not. So look at this. The remains of the tooth. The alternative of this is crown lengthening. And after crown lengthening, maybe extraction. Because you get to bifurcation. You decide. So I do my impression, and the impression is quite easy. I need a black cord into the sulcus, a green one to open the sulcus. I can take a digital impression, I can take analogic impression, it's about the same stuff. What I can do now, I can place also the provisional intraorally, wait a few minutes, and ask the patient to close gently. So I push the cord and I open the sulcus. And when I do that, I can take a beautiful impression. It's very, very easy. I like the silicone better than polyether, because the resilience of silicone is better than polyether. It's not more precise, but I can get very precise impressions. And then your technician know better than me that when you work vertically, you can get higher precision compared to the horizontal preparation, chamfer or shoulder. So I get the final impression, analogic impression, And this is not the chamfer. This is the epical part of my finishing line, okay? I don't have a chamfer anymore. You don't have to think like chamfer. Think chamfer men, chamfer ladies, please. Don't think like that. Just think that you got a finishing area and you got epical to the point where you want to place your crown margin because you want to see epical. So this is the impression and this is the final crown. Do you think that this crown is going to break when I go through the cementation? Look at the margin. Okay? So it's impossible. It's very safe. And then this is the final crown. And if you look at the